Okay, we're going to go ahead and do the patho of TB, asthma, and COPD. Open your books. We'll start on page 528 in your med surg text. Okay, we're going to talk about TB. It's on page 528 to 33 in your book. We're going to talk about both the latent and active TB. So this pretty disgusting picture shows how when someone coughs or sneezes, the water droplets then latch on to like small particles in the air. Someone is standing nearby and inhales these particles, and if the patient was positive for tuberculosis, then the individual inhales the air particles contaminated with the gram-positive bug, which is the microbacterium. The body responds with an inflammatory response, and then what happens is essentially the tuberculosis forms a granuloma, and in an effort to stop the infectious process, it's like essentially walled off. It then becomes dominant. It only develops later when the individual becomes compromised or susceptible to the actual infection. So, a couple of other things about tuberculosis. Unfortunately, it's on the rise in the United States, and that's due to the number of HIV positive individuals and the fact that we're unfortunately developing resistant strands due to lack of compliance with the medication regimen. And it's prevalent in countries where they're considered third world countries. People are immunocompromised, and we already talked about the AIDS population. Really, if it is a chronic reoccurring infection, but one, it's hard to catch. You have to have repeated exposure in a relatively confined area, and if treated properly, there's no residual. The lungs tissue will heal fine and not be permanently affected. Okay, so go ahead and turn in your books to page 529. There's a table 28.9, and we're going to look at the difference between latent versus active tuberculosis. So if you have latent TB, it means that you've been exposed to the gram-positive bug. Your body has effectively walled it off, and you have latent TB. These individuals, they don't feel sick. They don't have signs and symptoms. They cannot spread it to other individuals, yet they do need to take a drug therapy regimen, which we'll talk about a little bit. Someone who has active tuberculosis, remember we talked about how someone would acquire TB, how they would wall it off. Months, years later, their body has become susceptible to the actual tuberculosis, and then they become active. They develop signs and symptoms as listed on page 529. They are considered contagious, and they have a very intense drug therapy regimen that they must go through. So really early detection with effective drug treatment and preventing spread to others when it's active. And so how do we find out? You guys are all familiar with the PPD. The PPD, you guys all had to have one to get into nursing school. So we do that. Just because someone has a positive PPD does not mean that they have active tuberculosis. It means that they possibly have been exposed to it. What does it mean? It means, hey, we need to go ahead and get some further testing. We need to be able to confirm what's going on here. Okay? So we need to look at the fact that what's the induration look like? The induration, or the positive, what we consider the positive reading. If you guys flip back in your books to page 494, so go ahead and take a minute and flip back in your book to page 494. It tells you the differences as far as the PPD readings. Okay, and this is something that's good to know. And so you can go over page 494. It talks about the different sizes and what that means. Then we need to go ahead and realize that, okay, positive PPD, we're going to need to get a chest x-ray. You can see what a chest x-ray would look like if someone has tuberculosis. Then we need to go ahead and get the sputums. That's really what we need. Chest x-ray cannot diagnose it either. It can just show that there's been some lung changes. We need sputum, and the sputum will help us to positively identify tuberculosis. Okay, next we're going to talk about asthma, which is on page 561 in your book. Okay, so what's going on with asthma? First, on page 563 in your text, there's a really nice map that outlines the response that we're going to talk about. So the individual is exposed to a trigger, and triggers are also outlined in your book. And about 30 to 60 minutes after that trigger, then signs and symptoms start to develop. The signs and symptoms that the individual develops are mainly because of airway inflammation. And that's what the picture on the left is showing, airway inflammation. You have airway inflammation, which you can see you have the inflammation of the mucosa, which narrows the inside of the airway. You have excess mucus production, and you have edema. Remember from anatomy and physiology, you have smooth muscle that's wrapped around your bronchioles. And as these smooth muscles constrict, it narrows the airway. So it's kind of almost like a triple whammy, where you have the inflammation, the edema, and the excess mucus production. Even when an individual who suffers from asthma is not having an acute attack, they can still have airway inflammation, and they might still suffer from edema on a chronic basis. And just know these chronic changes can actually lead to what we call remodeling. This is just kind of reiterating what we've already talked about, so you can read through this slide if you need to hear it again. Okay, so the signs and symptoms, or what's going on when someone is experiencing asthma. First of all, there are a lot of triggers. Triggers are things that cause an asthma attack. There's a table on page 561. Many of these triggers you're familiar with. You can read through them. Sometimes people, though, are surprised that stress hormones and GERD could actually trigger an asthma attack. People who are experiencing an asthma attack do so because of the physiological changes that we talked about. A lot of times there is this sensation that they describe as a chest tightness. What you might observe is that they're coughing, whether it be productive or not. They'll have some dyspnea and some wheezing. These symptoms, they may come on quickly or kind of slowly, and attacks can last for hours or even days. As the asthma attack gets worse, the cough does increase, and the patient can actually experience tachycardia, tachypnea, prolonged expiration. The wheezing could get louder, and on more severe attacks, you might actually see where they're using accessory muscles, might have what we call some intercostal retractions, and maybe some distant breath sounds. If it is a persistent, severe asthma attack, the patient might actually become very fatigued and only able to speak maybe one or two words between breaths. Often the patient, though, experiences anxiety and restlessness as their dyspnea gets worse. And so we need to make sure that we are watching carefully for an increased worsening of this patient's signs and symptoms. We'll talk a little bit more about status asthmaticus later in some slides. Okay, so now we need to actually diagnose asthma. It can be tricky because a lot of times in between attacks, patients will appear normal. So we talk to them, and we talk to them about their signs and symptoms. If you guys turn to page, let me find it here in your book, 565, there's a table that shows you how we classify asthma as being intermittent, mild, moderate, or severe. So when we're asking questions about history, we're specifically asking questions about how often do you have your symptoms? Are your symptoms waking you up at nighttime? How often are you using your SABA for these symptoms? Do you feel like your asthma is interfering with normal activity? And so those are some of the questions that we can ask to help determine what type of asthma they have. Talk to them about their subjective findings, but you also do an exam and look for objective findings. You know, is there wheezing? Is there anything that suggests that they have, labored breathing? They're dyspneic. They're using accessory muscles, etc. Talk to them about triggers. Have they noticed any triggers? Have they kept a log possibly of triggers? And then what we can do diagnostically is to evaluate the respiratory function. Obviously, we want to look at their O2 sat, but often if they're in between attacks, it will be normal. Possibly ABGs, but once again, they'll be normal. When you're looking at the picture on the right, this is a picture of an individual undergoing what we call PFTs, or pulmonary function studies. Okay, PFTs, pulmonary function studies. We learned about pulmonary function studies in the respiratory assessment chapter. Again, a lot of times patients, if they would just go in between attacks, would have normal PFTs. So typically they're told to not use any bronchial dilators up to 12 hours beforehand. Then to come in with their bronchial dilator, their inhaler, and they would run PFTs with and without the bronchial dilator to see what is considered a significant change. In class, we will actually talk about what we call a PEFR, which is a peak expiratory flow rate. This is actually done by the patient at home with a handheld device, and it measures the peak flow and helps the patient to monitor their progress on a daily basis. And so they will actually keep a log of this. We'll talk about it more in class, but a PEFR is a good diagnostic tool on a daily basis. We want to tell the patient that what we need to do is control your symptoms, decrease the number of attacks that you're having, hopefully prevent them all the way, and to teach them what they need to do during an acute attack. A couple of additional things, though, for diagnostics would be blood tests. There's not a lot of blood tests, but sometimes they do actually look for elevated eosinophil counts. And then also a lot of times patients probably are going to have to undergo what we call allergy testing. And allergy testing is done to see if we can identify specific allergens that a patient needs to avoid. We'll actually talk about how to take care of the asthma patient and all the medications and nursing interventions in class, and we'll do the same for tuberculosis. Okay, next we're going to talk about the pathophys of COPD, which starts on page 580 in your textbook. Okay, so chronic obstructive pulmonary disease. Page 580, as we said, just some key words that you're going to want to focus on when we're talking about this particular disease. It's preventable. We'll talk about what patients can do to avoid it, but currently third leading cause of death in the United States. Does have a genetic component. We'll talk about that. And it is chronic and progressive. And so the chronic condition is an inflammatory airway response. And as it progresses, you have more restricted airway flow. Also, what you want to put right here is exacerbations. This is a disease that has periodic exacerbations, and a lot of times when these exacerbations occur, the patients end up with respiratory infections. What can we do to prevent developing chronic lung disease would be cigarette smoking is the leading issue. Occupations that you're exposed to dust and chemicals, making sure that we have proper mask uh, exposure to secondhand smoke, and pollution. The genetic component is what we call a deficiency in the alpha-1 antitrypsin, and this is a protein. And it is only present in about 1 to 2% of patients that actually have COPD. So, this particular protein helps maintain normal lung function, and if a patient has a deficiency of it, they're more likely to develop signs and symptoms of emphysema, because that particular protein actually limits lung tissue destruction. But it is not very prominent or prevalent in those individuals who actually end up with COPD. Okay, so what's going on in COPD is the patient can develop either chronic bronchitis, and this is where we have excess mucus production, characterized by a cough that lasts 3 or more months in 2 consecutive years. So a cough that lasts 3 or more months in 2 consecutive years, typically, caused by smoking, cigarette smoking, but can be caused by other things. And so you can also see that we have the excess mucus production, but you can see that we can also have some narrowed airways, and they become obstructed. As this progresses, then we also have what we call decreased ciliary action, which means that the patient then is unable to clear the secretions as they should, get rid of the secretions, and then this sets the patients up for repeated respiratory infections. Also, patient can develop what we call emphysema. Emphysema is actually characterized by destructions of the walls of the alveoli. This leads to abnormal air spaces. So we have destruction of the walls of the alveoli with abnormal or enlarged air spaces. And once again, cigarette smoking is usually the causative factor. So as you have this alveolar wall destruction, you also have to realize then you're going to have a corresponding loss of the surface area for the alveolar capillary diffusion. So as you lose this space, then it is reduced, and gas exchange is affected. And then we also have a loss of elastic recoil, and this decreases the amount of air or volume of air that is passively expired. Okay? And so you have air trapment. And these are the 2 main components that are considered to be chronic lung disease. This is just a brief recap of the main components of chronic bronchitis and emphysema. These are some of the signs and symptoms that a patient can have that's experiencing either chronic bronchitis, emphysema, or both. They feel like they can't breathe or take a deep breath. They have what we call a smoker's cough and usually have excess sputum production. A lot of times they have abnormal breath sounds, being wheezing or rhonchi, and you can look at additional signs and symptoms that are located on page 29-17. This picture just shows you blue bloaters versus pink puffers. Blue bloaters are considered your chronic bronchitis, and your pink puffers are considered emphysema. Okay? So what we have here is a blue bloater who's dusky to cyanotic, has lots of sputum, has a cough, is hypoxic, has hypercapnia, which is an increased CO2, is acidotic. Acidosis is a pH less than 7.35. Increased respiratory rate, which would be tachypnea. They have exertional dyspnea, and they can have cor pulmonale, which we will talk about in class. A pink puffer has an increased CO2 retention, which would be hypercapnia. Usually not too cyanotic. They have pursed lip breathing, dyspnea. They can have hyperresonance on chest percussion, orthopnea, which is difficulty breathing sitting up, a barrel chest. The barrel chest is due to the air trapment, the chronic air trapment. Okay, exertional dyspnea or dyspnea when they're exercising, prolonged expiratory phase, speaks in short sentences, is anxious, uses accessory muscles, and usually is very pale, not pale, but very thin because of the fact that they are, it's just difficult for them to eat. It takes way too much energy. Okay, potential chronic complications of someone who is suffering from chronic lung disease would be, first, they could possibly have or develop what we call cor pulmonale. Cor pulmonale is associated with pulmonary hypertension. So think about this. As the lungs become stiffer because of the disease process, the pressure in the lungs go up. As the lungs become stiff, as the right ventricle is trying to pump its blood volume through the pulmonic valve out into the pulmonary system, it becomes more and more difficult because the lungs are stiff and it's hard for the right ventricle to empty its blood volume, and over time this causes the right ventricle to enlarge. So when the right ventricle enlarges, then the patient develops what we call cor pulmonale. It can lead to right-sided heart failure. Right-sided heart failure. Exacerbations, that's just a flare-up of the disease. So when I say exacerbation, that means flare-up. Okay? And when this happens, it's usually because they've developed a respiratory infection. They're having an intensified signs and symptoms, and it's really associated with poor outcomes for people who have chronic lung disease because they do not return to their baseline. Respiratory failure is defined by blood gases. Respiratory failure is not a disease, but a condition of a disease. There are many, many reasons people go into respiratory failure. Chronic lung disease is one of them. And the patient joins a club called the 50-50 Club, which we don't want them to join, but they do. And that means that their PaO2 and their PaCO2 are both at 50. And so acute respiratory failure is defined by the 50-50 Club, or blood gas results. Okay? And then obviously these individuals have a disease that is progressive. It is not reversible. They're going to suffer with it for the rest of their life. So often they become depressed and suffer from anxiety, especially as their condition progresses. These are some of the diagnostics, many which we've already been through because of the fact that we talked about asthma previously. So these should be familiar. A couple of different ones, or something I want to point out, is that when we do a CBC, people who suffer from chronic hypoxia often have an elevated red blood cell count. And so sometimes we do find that with people who have COPD, that because they have had this disease process for many years, that they have an elevated blood cell count, red blood cell count. And then there is a test where they actually have to walk. Prior to them walking, we will actually see what their O2 sat is, have them walk for X amount of minutes or exercise, and see what their O2 sat is afterwards to determine what kind of desaturation occurs. Okay? The other one that I don't have on here would be that they would actually check to see if the patient has the deficiency of the antitrypsin protein. So they might actually check to see if a patient has that deficiency or not. And I think that's it. There are a lot of really good YouTube videos out there if you need extra help trying to learn the pathophysiology of chronic lung disease. I would certainly encourage you to listen to those as needed. All right, so what we'll do in class then, guys, because this is something that you need to have listened to prior to coming to class, is we can now just focus on taking care of these patients and what we need to do.